Assalamualaikum. Today I'll discuss about anti-tubercular drugs. At first I tell you the name of anti-tubercular drugs. It is divided into two categories: first line drugs, second line drugs. Now, what is the first line anti-tubercular drugs? First line anti-tubercular drugs is I for isoniazid, rifampicin, ethambutol, pyrazinamide, streptomycin. First line, this is the first line drugs, anti-tubercular drugs. Now, what is the second line anti-tubercular drugs? Second line anti-tubercular drugs. One is amikacin, aminosalicylic acid, clofazimine, ciprofloxacin, levofloxacin, then rifabutin, now first I will tell you the mechanism of action of isoniazid. Inhibit mycolic acid, which helps to inhibit cell wall synthesis. Inhibit mycolic acid synthesis. Then indication in TB and latent TB. Now, what is the adverse drugs reaction? Adverse drugs reaction is peripheral neuropathy and hepatitis. One is peripheral neuropathy. Second is hepatitis. Peripheral neuropathy and hepatitis. Now, mode of action of this isoniazid, it is bactericidal. Now, daily adult dose is 5 milligram per kg per day. Now, if a patient present with jaundice, if a patient present with jaundice, what should you do? If patient present with jaundice, stop the drugs. Then serum bilirubin and SGPT should be done. Then if, if as we know that isoniazid cause asymptomatic hyperbilirubinemia, if it is used with rifampicin, then it is called hepatitis. So stop the drugs, then investigation should be done. Then we should use, if patient recover from jaundice, then we use less hepatotoxic drugs, start with less hepatotoxic drugs. Then we can use optimum dose. Then you use other anti-tubercular drugs. Every 2 to 3 months we should investigate the serum bilirubin, SGPT and AGOT. Now if a patient now why isoniazid is used in tuberculosis patient? It is must? Why it is must? Because it inhibits cell wall synthesis. It inhibits cell wall synthesis. So other anti-tubercular drugs can easily enter into bacterial wall or bacteria, and disrupt the bacteria or bacterial wall. And chemotherapeutic synergism for this isoniazid is must. Now we discuss about rifampicin. Rifampicin bind with bacterial DNA dependent RNA polymerase enzyme, inhibit RNA synthesis. It inhibit RNA synthesis. So if it inhibit RNA synthesis, bacteria will not uh, growth. Bacteria will not uh, inhibit RNA synthesis. This will help in no growth and no multiplication. Anti-tubercular drugs effect. Then what is the indication? Indication is TB and leprosy. Adverse drugs reaction is hepatitis and flu-like syndrome. Flu-like syndrome. What is the what we can use? 10 milligram per kg per day. If we use rifampicin with OCP, patient may pregnant. If you used rifampicin with anticonvulsant, seizure occur. If we used rifampicin with coagulation, anticoagulant drugs, then bleeding tendency. It is also bactericidal. It is also bactericidal. Now we will discuss about streptomycin. Streptomycin, its mechanism of action is inhibit protein synthesis. Inhibit protein synthesis. Indication is TB drugs. Indication is TB drugs. Adverse drugs reaction is ototoxicity, nephrotoxicity. It is also bactericidal. 15 milligram per kg per day can use. Now, pyrazinamide. It if it is its mechanism is unknown, but some school thoughts is one school thought is it inhibit tuberculin bacilli by producing acid. Pyrazonic acid inhibit bacilli by producing acid, pyrazonic acid. Adverse drugs reaction is indication is TB. Adverse reaction is hyperuricemia and hepatitis. There is also bactericidal. Can use 25 milligram per kg per day. Now ethambutol. It is also a cell wall inhibits cell wall synthesis. Adverse drugs reaction is retrobulbar neuritis. It causes retrobulbar neuritis. Peripheral neuropathy. Okay, it is a bacteriostatic drugs. Bacteriostatic drugs. You can use 15 to 25 milligram per kg per day. Now, why we use steroid with antituberculin drugs? Why you use steroid with antituberculin drugs? Absolute indication is bilateral adrenal hyperplasia, tuberculosis. Bilateral adrenal TB. Then adrenal TB. Then tubercular meningitis. For adhesion prevention. Tubercular in causes pleural effusion. Prevent adhesion. To prevent adhesion actually. Now, why therapeutic failure occurs? Therapeutic failures occurs. Why therapeutic failure occur? Treatment inadequate. Treatment and inadequate resistance occur. Now, first line drugs index therapeutic index more. In second line drugs therapeutic index less. This is all about antituberculin drugs. At first I tell you some Antituberculin drugs. At first, I tell you some antituberculin drugs as soon as the rifampicin, ethambutol, pyrazinamide, streptozotocin. Secondary drugs: amikacin, aminosalicylic acid, clofazimine, ciprofloxacin, levofloxacin, rifabutin. Therapeutic index is more in first line antituberculin drugs, less in second line antituberculin drugs. Why therapeutic failure occurs? Because treatment is inadequate and resistant occur. Then isoniazid, rifampicin, streptomycin. I tell you the mechanism of action at first, then indication, then adverse drugs reaction, mode of action of the bacteria, then adult dose, then if any complication or um, anything else occurs. Isoniazid at first, then rifampicin. Isoniazid, rifampicin, and ethambutol is pregnancy safe, but streptomycin and pyrazinamide is not pregnancy safe. Streptomycin is contraindicated in pregnancy. Contraindicated in pregnancy. Pyrazinamide, with isoniazid, pyridoxine is used because it is called peripheral neuropathy. Peripheral neuropathy. Why peripheral neuropathy occurs? Because it excrete vitamin vitamin B12, B6. Excrete vitamin B6. Then it is called. Then it is occurs. Peripheral neuropathy. If it we can but we can prevent this peripheral neuropathy by using pyridoxine 15 milligram. This is all about antituberculin drugs. Thank you very much.